Good morning, everybody. Welcome to the MGB Biopharma presentation. My name is Raymond Spencer. I'm the CFO of MGB. We're a private Scottish company, and we're developing novel anti-infectives. Our lead compound is MGB BP3, which is indicated for Clostridium difficile. So it's often said that good drugs declare themselves early. What I can tell you is that now that we're in the middle of a phase 2A study, in fact coming towards the end of that study, our compound is ticking all the right boxes. And it's a novel first-in-class therapeutic. It's potent, rapidly acting. It's well tolerated. It's safe, sparing of the microbiome. And it's already showing good initial and sustained cure rates in patients in our phase 2A study. So we expect to complete the study at the beginning of next year, Q1 2020, at which time we expect to confirm both superiority, efficacy, and safety. So we're looking at all of those. We're currently looking for funding for phase 2B. So this is Clostridium difficile infection. So on the left-hand side, you can see the disease indication. It's an acute infection of the large intestines. The symptoms range from mild diarrhea through pseudomembranous colitis through to sepsis and death. On the right-hand side, you can see that the bacteria exists in two forms. First of all, the vegetative form, which produces the toxins, and that causes the disease. And then the spore form, which is dormant, inert, nothing but bleach can touch the spore form. So the trick is to kill the vegetative form before it can form a spore, and that's what we do. A lot of data on this slide. This really just shows the cycle of C. diff. So a subject will ingest the spores. If they are susceptible to this disease, they may have an impaired microbiome through prior broad-spectrum antibiotic use. The bug will then germinate, release the toxins, cause the disease. You treat it with an antibiotic, a bacteriostatic antibiotic, and then immediately we will try to form the spores. So it takes 10 to 15 hours to form those spores. Once it does so, it's no longer susceptible to antibiotic treatment. So you need a rapid-acting, potent bactericidal antibiotic, and that is what the market currently needs. So what's our clinical evidence? So we're currently in a phase 2A study in North America. We're treating 3 groups of 10 patients, so a total of 30 patients. We're looking for safety, initial cure rate. We're also looking for sustained cure rate, as well as pharmacokinetic data, and we're looking at the microbiome. So this is the data that we've seen so far, and this, I hope you will understand, is very exciting because we've treated 15 patients so far out of the 30. The first cohort was at the lowest dose, 125 mg twice daily. 10 patients enrolled, all completed their course of treatment. Of those 10, 9 achieved an initial cure, only 1 recurrence. Of those 9 that achieved an initial cure, 8 showed a sustained cure at 4 weeks. Some of our centers, not all of them, are following up for 8 weeks. And what I can tell you is that 6 out of 6 patients that have been followed up for 8 weeks also show a sustained cure. In the second cohort, we have enrolled 5 patients. 3 have completed their 10-day therapy. All 3 have shown an initial cure. So if you add the data up, the initial cure rate so far is pointed towards 92%. The sustained cure rate is pointed to 84%. You compare that with the existing drugs, Vancomycin is 90% initial cure, 65% sustained cure. So we're pointing towards a superior drug compared with existing treatments. In the phase 1, this was healthy subjects, and we dosed up to 2 grams a day for 10 days. No SAEs, no dose-limiting toxicities. It was well tolerated. We looked at the microbiome at the beginning and the end of treatment, and the results there were that the subjects had a healthy microbiome at the beginning and at the end. These were healthy subjects, and none of them had C. diff, but they did have, as part of their microbiome, they had other forms of Clostridia in that class, and our drug killed all of that class. So what's the preclinical evidence? I mentioned that you need to kill the bug before it can form the spore. So this is our evidence of our drug doing exactly that. If you look at the top row, we're comparing our drug against vancomycin at 2, 4, and 8 times MIC. And there are 3 different strains of C. diff. On the right-hand side, top right, there's a hospital strain. You can see the top lines there are all vancomycin. So the strain is resistant to vancomycin. At best, vanc is bactericidal. All 3 doses of our compound, however, come right down to the bottom. So we kill the bug within 2 hours. Same with the reference strain in the middle at the top. Again, we kill the bug within 2 hours. Vancomycin, at best, is bacteriostatic. And then top left, that's the NAP1027 hypervirulent strain. Again, ours is the only drug that kills the bug within 24 hours. And within 8 hours, we've got a better than log3 reduction. A better than log3 reduction in cell count, that means it's bactericidal, not bacteriostatic. And at the bottom here, you can see data from other companies and other trials. This is not our data, but that shows a time kill against the NAP1 strain by Summit's compound, rudinilazole, bottom right, fidaxomicin and vancomycin. The important thing to note there is they all take 24 hours to achieve their effect, by which time the bug will have already formed spores. Also, our preclinical data, this is a hamster model, typical hamster model. On the left there, that's really showing that the survival curve is the same with our drug and with vancomycin. But at the end of 13 days, we sacrificed the animals, we counted the bug in the gut compartments, and what we showed there is a significant reduction in the bug burden in those gut compartments. So this is a log scale, so better than 100-fold reduction in the bacterial count. So what's the commercial rationale? I mean, clearly when you're developing a drug, you want to show that it's safe, efficacious, but is there market? And there are a number of anti-infective companies who have launched new products or have failed to show that there is a commercial position for their drugs. I don't think that's the case with C. diff, because we know that there are 500,000 patients per annum with this disease in the US, 30,000 deaths. It's classified by the CDC as an urgent threat in 2013 and repeated just, I think it was yesterday or the day before that they came out with their new report. So it's still an urgent threat. It's the most common form of hospital-acquired infection in North America. And sales in 2016, according to global data, were about $600 million. High growth rates. I mean, it is a disease of the aged. So, I mean, the 2 highest risk factors is prior use of antibiotic and being over the age of 65. So looking around this room, well, I'm going to be 65 next year, so I might be in that category. I mean, interestingly, the Infectious Disease Society of America changed their guidelines in March 2018. They withdrew metronidazole. And what that did is it promoted the sales of both vanc vancomycin and fidaxomicin, so their sales grew by 20%. If we can show superiority, almost certainly IDSA will include our drug in their guidelines. And we think we have a very good chance of becoming first-line new gold standard of treatment. So in summary, we bring a new paradigm to the treatment of Clostridium difficile associated disease. We're the only drug that is rapid, potent, bactericidal that has the ability to kill the bug before it can sporulate. By doing that, you help to prevent recurrence, and as well, you should be promoting recovery of the microbiome. As well, we're very active against the hypervirulent strain, whereas the other compounds that are currently, and there are only 2 compounds that are approved for this indication, they're not effective against that strain. So we have qualified infectious disease product status, and if we can show superiority and sustained cure rates, as we are beginning to show, if we can prove that in a randomized trial, then we would expect to be the new first-line treatment and enjoy significant sales in the US and elsewhere. So that's me, MGB Biopharma. Thank you very much for your attention.